We offer education, community, and innovative healthcare solutions to guide you on your wellness journey. Tonight, we're thrilled to welcome a very special guest, Dr. Matt Sager. Dr. Sager is a cardiologist and data scientist focused on improving cardiovascular care through machine learning. As a cardiac electrophysiology fellow at the Texas Heart Institute, he works on developing risk prediction models and tools for cardiovascular diseases with a special focus on diabetes-related complications. He graduated from internal medicine residency at UT Southwestern Medical Center and received his medical degree from the Indiana University School of Medicine. He also graduated with a degree in computer science with honors from Bucknell University and a master's of science in bioinformatics from Indiana University. Gosh, you're so impressive. Dr. Sager is passionate about using data to create personalized, equitable healthcare solutions that improve patient health outcomes. His current research focuses on using machine learning and AI to improve risk prediction and tailor medical therapies to identify and treat cardiovascular disease. Dr. Sager, welcome to our community. Welcome.
Thank you. I'm incredibly excited to be here. This is a topic that I'm very passionate about, and I have a lot to say. I'm really excited to jump in.
Oh, well, thank you for being here. Can you just, before we get started, tell us why you decided to become a cardiologist, how you're marrying AI, machine learning, technology, computer science with cardiology, and how you're helping your patients and society as a whole?
Yeah, well, thank you again for inviting me. My story is I was a programmer, a computer scientist prior to medical school, got very tired of just staring at computers all day and wanted to do something that can combine biology with technology, and medicine was the perfect overlap with those two interests. And what I really strive for and what my big research interests are is finding the right treatment, because we have so many treatments for the right patient at the right time. So you have lots of different medicines that may help certain people more than others, and having that connection and figuring out what the best medicine is for a patient and someone that comes to talk with you is incredibly important. So it's what I've really strived to do over the last decade or more now.
The quickest way to clear out stuck poop.
Can you share your background in research and what you've done in the past?
Yeah, so the diabetes space has been something that I've been interested in now for the last 7 years, dating back from the SGLT2 trials, getting involved with some of those, and then now with more of the GLPs. And liraglutide is a medicine that's been around for a while now, almost 2 decades. 2004 is when it first came out or first was around. And one of the studies we've done is looking at why or how liraglutide helps reduce weight. And specifically, we looked at MRI results in people with liraglutide at starting, and then after 6, 8, 12, 16 weeks, and see the decrease in fat within the muscle itself, not just adipose around your belly, but the amount of fat that gets reduced in the muscles in your legs and thigh is pretty substantial. And that was very significant, a very positive finding that can help explain why and how these medicines are working to reduce weight.
Yeah, I would love for us to get into that. But before we start, maybe you can distinguish or differentiate a little bit between, well, like the general, for anyone who's new. I mean, we have some people in this community who have been using GLP-1s for a very long time, myself included, but others are brand new and they're coming on this call to learn about GLP-1. So can you distinguish between liraglutide, semaglutide, tirzepatide, and just tell us how GLP-1s work on some of the overall benefits?
Yeah. So the story of GLPs is kind of rooted in serendipity. So we've noticed these medicines have been around for 2 decades. Like I've said, exenatide was the first one that came out. The problem with these medicines is that they were daily dosing. So imagine having to inject yourself every single day. They were not really feasible except in very specific population. What has changed, though, is once we started being able to formulate these on a weekly basis, and that started with semaglutide. All these that end in utides are all GLP-1 medicines. So what is GLP? So GLP is a medicine or a hormone that is naturally produced in the body. It's expressed in the pancreas and some in the intestine as well, and it acts on lots of different parts of the body. It acts in the brain, it acts in the stomach, it acts in the pancreas, and then it acts in the intestine as well. And it has really positive benefits. We need this hormone to survive. It helps regulate insulin. It helps regulate a lot of the processes that our body needs on a day-to-day basis. So GLP-1 agonists, or medicines that are like the natural hormone, have been around and become really popular. What we're starting to learn too are these other medicines like GIP, another naturally produced hormone. When you combine it with GLP, so you have GLP and GIP, you get Tirzepatide. And that's another very common medicine that has added benefits from just the GLP. You get this GIP, so you get the liver benefits and a few other things that we can talk about as well. But the key important thing here is that a lot of these are naturally produced hormones. We're just mimicking what the body naturally does, but kind of ramp it up in a more beneficial or additive way.
Yeah, I would love for you to discuss that, and we can talk about the benefits of tirzepatide versus semaglutide, liraglutide. But can you tell us all the added benefits besides weight loss? And a lot of people know these classes of medication for either diabetes or weight loss, but can you talk to us a little bit more about all the additional benefits that come with these classes of medication?
I think we could spend a whole hour talking about just the benefits. Sometimes it's easier to talk about the negatives and the benefits because they're so long. Just to give a general overview, is it helps heart health. So it acts in the heart. It helps improve blood pressure. It helps improve cardiovascular death. These people live longer, and it was one of the trials actually showed that you live up to 6 months longer in a 5-year trial, which is incredible, of dying of any cardiovascular cause. It helps decrease fat in the liver. It helps kidney disease by improving the amount of protein that the kidney expels in the urine. It helps regulate appetite and, of course, all the weight loss benefits. And then it also helps in the brain with some neuroprotective disorders as well. And we can even talk about women's health and fertility. One of the best articles I've seen since the last time we've talked is the Ozempic fertility craze, where people on Ozempic are all of a sudden now becoming pregnant because they decreases PCOS, and all these added benefits is really impressive and cool to see.
Yeah, and a lot of people are microdosing it now, especially within our company. So not just for its weight loss benefits, but for all the anti-inflammatory benefits and so forth. Can we touch on Tirzepatide as an example and talk about the role of the GLP-1s in this process of, I'm sorry, lipolysis and fat burning?
Yes, so Tirzepatide, because it has that GIP hormone as well, does really well working on the liver. So the way that GIP helps upregulate the liver and lipolysis is that it works on the fat cells to help break them down. So you get this really nice benefit of decreasing fat by actually working on the fat cell itself. We don't see that as much with GLPs, although there is some, but that GIP is really what drives that lipolysis benefit with some of these medicines.
Mm. Ones playing, and how do they prevent yo-yo dieting or weight regain?
Yes. So yo-yo dieting is something that we've all struggled with if you've ever tried to be on any sort of diet. What these medicines do is it helps regulate homeostasis. It helps keep your body at a more level, even-keeled pace. So because it works in so many mechanisms, and let's just talk about two of them, the stomach and the brain, to help prevent that yo-yoing. So the way it works in the stomach is it helps prevent gastric emptying. Food sticks around in your stomach longer. So you feel full longer. You have less of a craving to eat throughout the day. It keeps things, when food's in your stomach, it keeps things nice and even. The second way it works is decreasing the cravings that we have in the brain. It increases our satiety, so we feel full from a brain or mental standpoint as well. So you have these two, we call it the stomach-brain fat axis, is working together to help prevent you from having these massive cravings throughout the day, yo-yoing when you come off a diet, and they work really, really well.
Mm. And can you share with us, you mentioned all the disbenefits, but side effects? Let's talk about side effects. And why do you typically tell patients to slowly titrate up as opposed to go to a specific dose of 0.5 or 5 milligrams?
Yes. So these medicines are naturally in the body, but they're not used to, your body's not used to having them at this concentration. So that's why we start low. So the way the medicines work can help explain why some of these side effects exist. So when we say that the medicine acts by not letting food pass from the stomach, food sits around in the stomach, you're going to feel nauseated. And that's by far and away the most common side effect that we see. It tends to go away as the time goes on. I usually tell patients 3 to 4 weeks, and then things get a lot better. But they can be pretty drastic. Up to 40% of people will have some nausea when they take this medicine. It's expected. It's normal. I always tell people to start slow, eat what you can, and just understand that it's going to happen. The second biggest side effect that a lot of people have is diarrhea or constipation. I can't predict, no one can predict what you're going to have, but more likely than not, you're going to have something for the first week or two. It usually goes away. The long-term effects are pretty few. The 3 big things that I always talk about are pancreatitis. This medicine works on the pancreas. You ramp up the pancreas. In some people, you can get pancreatitis. This is especially seen in people that drink alcohol, is where you see it the most.
I'd like to make a comment, and where we see it is when dosing is not correct and dosing is too high. We have not experienced that at all with any of our clients, but having a friend who is an anesthesiologist, it is a real thing, but it often is contributed to the dosing.
You can get a delayed gastric emptying or gastroparesis. This is not as it's reported in literature, it's reported in the news. News stories love to pick it up. But diabetes is also a major risk factor for gastroparesis. So is it the diabetes causing this, or is it the medicine? It's very hard to tell, but it is a risk. And the third is, and it hasn't been shown in humans, it has been shown in preclinical animal studies, is it can cause thyroid cancer. That's why the commercials always say avoid if you have a history of MEN syndrome or thyroid cancer. There haven't been human case reports of this, but it is seen in animal studies. So it does have that black box warning on the FDA if you've had thyroid cancer, which is a small proportion of people.
And from what I understand, it's medullary thyroid cancer, which makes up 2% of all thyroid cancers, correct?
Correct. MEN.
And I will say there has been no evidence at all that that has occurred in humans. This was only done in the rodent study, and it was based on higher dosing as well.
Syndrome type 1A to be specific. So it's a very, very small subtype.
Subset, and it's only been shown in animal studies. So let's debunk some of the myths that these medications can make you go blind and cause Ozempic face, Ozempic butt. Can you just talk about that and touch on some of these myths that are floating around?
So the big thing to take away is that people love to say, we have no data. We don't know what this medicine does. We do. This medicine's been around for 20 years. We have lots of data. We've known that liraglutide or liraglutide has caused weight loss since it was approved in 2014. We've known exenatide since 2004. So a lot of these are just because it's becoming more popular. People like to, news stories love to jump on things, is to say it bluntly. I think the eye blindness, if you actually read the paper, was not actually blindness. There's a lot of diabetes progression, which can cause blindness. Ozempic face, if you lose weight very quickly, you're going to have fat distribution issues where you can have sunken faces, or you may lose fat in certain places than others. A lot of that is how your body handles weight. Some people distribute weight in more the midsection. Some people distribute weight in their thighs and hips. Some people distribute weight in their face. And the order in which we gain weight is a lot of times the opposite happens in how we lose weight. So.
And again, I will also say dosing is very critical here, because if you do not have any appetite at all and you're not eating very much, obviously you're not going to be getting the amount of protein that is truly required for, it's different for everybody, the requirements that are optimal for you. But if you're not hungry, chances are you're not getting proper nutrition either. And that's where these things with, hair loss and blindness and losing too much muscle, all of that is related to dosing.
A lot of it is person dependent. I think the big takeaway is listen to your body. If you're having side effects, slow down. This is not a race. This is try to get to a place where you can be on a stable dose and then work from there. So start slow. Even a little bit of the medicine does well, but it is a dose dependent medicine. The more that you can take, the more benefit has been seen.
Okay, I'm so glad you're a cardiologist, because this is a question I have, and I saw it on social media, and I wanted to ask you. And I know we're going to talk about the heart health benefits, but I want to touch on this. Obviously, as you know, with any weight loss, you lose 20% muscle mass. That's very normal. If you don't exercise, you don't get adequate nutrition and protein, especially. Well, your heart's a muscle as well. How does this affect the cardiac muscle? Because I did see something that said, well, it affects the cardiac cells and it's detrimental to the cardiac cells. So you as a cardiologist, please debunk that myth. How does this affect the heart?
Well, it helps the heart positively. Yes, it works on the heart cells, but it does so in a way that's beneficial. So we know that there's fat around the heart. There's fat within the heart. When you have fat in the heart doesn't want to contract as well. It doesn't want to relax as well. The heart needs to relax to fill with blood. If it can only fill a little bit, then it can't pump as much blood forward. So we want the heart to be able to relax and stretch and fill with blood in a nice, even, normal way. So when we are on this medicine, and we know that this medicine helps decrease fat cells directly, it's going to work in the heart and decrease the fat that's within the heart. So we end up seeing improved contractility of the heart. We see improved relaxing of the heart. And we see improved blood pressure, decrease in the amount of, you don't want a heart that's too thick. I know you think you want your biceps to be bigger, you want muscles to be big. We don't want the heart muscle to be that big. So we actually see improvement in the heart muscle size that are all really positive benefits of these medicines. And even taking a step back, we know that this medicine helps decrease cardiovascular death. That's an amazing statement to have from clinical randomized trials. This medicine helps you live longer and not die from cardiovascular disease. It's such a profound statement that I love sharing people.
Yeah, we'll do a deep dive on all the additional benefits, but I want to talk about all the negative stuff. So long term, Can you stay on these medications? Like, do we know how they affect our bodies if we stay on them for 20 years, 30 years, 40 years? Are they safe? What would you recommend to patients who are starting their journey?
I always tell people that we have 20 years of data. So we have patients that have been on this for 2 decades and they do very well. The other thing to take away from it is that we know when people come off these medicines, a lot of times they end up regaining some of their weight. Some people regain all, but some people regain some of their weight. A lot of that is because they go back to the old habits of eating more than their body's telling them to. This medicine does such a great job of telling you to listen to your body, know when you're full, understand those body signals, so that if you do come off this medicine in 5-10 years, you know what to look for and to have healthy portions, continue the exercise that you've been doing. You're setting yourself up for success. I think where this field is headed, though, in the really exciting areas, is there have been some trials and phase 2 studies that have done once monthly dosing, which is incredibly exciting. So not having to do injections every week, but every month. And some of these newer medicines actually did not have the rebound effect. So when they came off these medicines, they did not have that marked increase in weight after coming off these medicines. People stayed more or less stable and stagnant in their weight. So I think that's where the field is going.
Interesting.
And that is once you've kind of maintained your weight, your desired weight, you can do what is considered a maintenance plan. So it could be taking 1 injection a month just to increase that signaling, but it also could be every 2 weeks. The goal is, while you're on these medications, is to get your habits, your kind of understanding why you go at certain times, your emotional eating, your boredom eating, your stress eating, getting that kind of under control and changing those habits.
And do you foresee a once every 6-month shot and once a year shot? Do you foresee that? I mean, where's the future of these medications, these classes of medications?
I really do. And so we actually have this in the cardiology space. We have staff.
Medications are approved for diabetes and weight management. Do you foresee a future where they're approved for long-term treatment of heart disease?
Yes. So the FDA has approved these medicines for now 4 reasons. The first is type 2 diabetes, and this has been around since 2004, like I keep harping on. The second is for overweight or obesity, and there's 3 medicines that have been approved for that. There's liraglutide, Victoza, Semaglutide, and Wegovy, and Tirzepatide with Zepbound are approved for weight loss. The FDA has approved it for cardiovascular risk reduction in patients with diabetes or overweight with obesity and cardiovascular risk factors like hypertension, hyperlipidemia, and that is Semaglutide or Wegovy. And then the most recent one is, as of last month, actually, December, the FDA approved it for sleep apnea. So Tirzepatide is now approved for sleep apnea, which is really impressive.
Yeah, as a cardiologist, how does that make you feel?
I think it's exciting. I think the CPAPs are very effective, but they can be cumbersome traveling with the CPAP, and it can disturb your partner. And having another avenue or medicine to improve sleep apnea is really exciting. Mm-hmm. But from the cardiovascular standpoint, I mean, it's a no-brainer. The fact that you can improve such a wide range of cardiovascular risk factors, from blood pressure to kidney disease to heart contractility and decreasing arrhythmias, just about everything within the cardiology space can get improved by these medicines.
Right, and blood sugar.
Yes. So cholesterol is an exciting one. So, I mean, we can get to the gene-specific area in which these medicines work, but the grand scheme is that they all work by acting in the liver to upregulate certain proteins that help improve HDL. HDL is the good cholesterol. And so what good cholesterol does is it helps decrease the amount of bad cholesterol we have in our bloodstream so that it can be expelled from the body. So we do see some good improvements in overall cholesterol, increases in good cholesterol, and decreases in bad cholesterol with these medicines. Blood sugar is the first reason why these medicines were approved. They work on the pancreas. They increase insulin response so that the insulin can help naturally decrease the amount of blood sugar that is in the body. It can work in the kidney by helping get rid of more sugar as well. So the total body glucose or sugar your body has goes down.
And so it's interesting. You hear a lot about GLP-1s and their assistance with Alzheimer's and dementia, and it could become a frontline drug to prevent Alzheimer's and dementia. Can you elaborate on that and how that works exactly?
Yeah, I think so. We don't have any clinical trial data in this space. It's very hard to run Alzheimer's and Parkinson's disease studies. What we do have is some observational data and some mechanistic studies where we think this might work. Because this medicine works in the brain and it has such profound anti-inflammatory properties is that we do see that it has some neurocognitive or neuroprotective properties as well. The extent at which it can work in Alzheimer's disease and Parkinson's is still, it needs to be formally assessed and calculated, but there are some pretty cool reports of Parkinson's disease symptoms improving with these medicines. And it's a really exciting area of research.
Someone put in the chat, can it help with PVCs of the heart, since we're on that topic? Can you touch on that?
No, that's such a, I think so. Now, this is me speaking as an electrophysiologist, so this is such a cool question. I think, so there's lots of reasons why you can have PVCs. Some happen because of electrical problems, some happen because of inflammatory problems. It's not going to hit the electrical problems of PVCs. Now, if you have some of the inflammatory reasons for having PVCs, mechanistically, I think that you could see a decrease in your PVC burden. That's such an interesting question. And actually, I'm going to write this down because I'm very curious at studying this. So that's an amazingly good question.
Well, thank you, whoever asked that. Rolanda, way to go. And I wanted to touch on retatrutide, right? Retatrutide.
Yes. Retatrutide, yes.
Yes. What are your thoughts around that? And where are we? Where is Eli Lilly on that?
Yeah, so the triple agonist. So we started with semaglutide, which is GLP. We added GIP to form Tirzepatide. Now we have glucagon agonists to form retatrutide. You can imagine that the weight loss benefits on each of these keeps improving. So you have semaglutide, which you lose about 15%. Tirzepatide is roughly 20. Retatrutide, the triple agonist, you're talking 20 to 25% body weight reduction. It was profound. It's working very well in diabetes. The one caveat that I've seen is that when you add glucagon agonists, there are some heart benefit, or there's some heart effects that may not be as detrimental or maybe as effective. And what I mean by that is in some people, they developed tachycardia. So they got some faster heart rates. Glucagon agonists seem to work in the heart differently than these other medicines. So they have to be explored a little bit more thoroughly. Where this medicine is working even better though is in the liver. So survodutide is GLP and glucagon, and that had FDA breakthrough designation in October for non-alcoholic fatty liver disease. So GLP and glucagon. So it's like you took semaglutide and glucagon agonist, and that worked incredibly well improving liver disease, decreasing liver fibrosis, liver fat, really incredible, exciting area that they're exploring. And that's on FDA fast track. So they've started 3 phase 3 clinical trials for that medicine to evaluate it in liver disease.
Oh, that's so impressive. Okay, so for anyone who doesn't know what glucagon agonist is, can you explain glucagon for our listeners,
yes.
please?
So glucagon is one of the best named hormones in the body. It's exactly like the name says. Glucagon is when your glucose is gone. It helps increase your glucose levels because the body thinks that there's no glucose in the body. So it works on a higher level. It helps regulate insulin sensitivity as well. It's another medicine or hormone that is released from the pancreas that has a lot of really positive benefits in helping insulin regulation, cell anti-inflammatory effects. It's a pretty powerful hormone.
Well, thank you for that. I had a patient who lost 30 pounds and her blood pressure also decreased dramatically. Is that due to the weight loss or is it the medication improving heart functionality?
A great question. So some of it is weight loss. When you lose weight, your heart doesn't have to pump as hard. The vessels are happier. They naturally, your blood pressure is going to go down. But it's not as simple as just weight loss. This medicine works in 2 other areas. Excuse me, I'm taking a quick sip. Medicine works in kidney by helping get rid of sodium. So sodium is a salt. When we have salt, water is retained, blood pressure goes up. So by getting rid of salt, getting rid of sodium, we're decreasing blood pressure. It's one of the reasons why this medicine works so well in decreasing kidney disease, because it helps regulate some of those electrolytes, those molecules in the kidney. The second reason this medicine works is on the vessel wall itself. So when you have high blood pressure or hypertension, your body's tricked a little bit. Normally, your blood vessels should relax when you have pressure. Sometimes these vessels constrict paradoxically, meaning they shouldn't be constricting, but they end up constricting, which makes things worse. Your blood pressure goes up even more. So GLP can actually act in the cell, the vessel wall itself, to help prevent that from happening. It helps relax the vessel appropriately to decrease the amount of pressure we have in our blood vessels. So works in the kidney, works in the vessel itself, and we've already talked about it works very well in the heart. So it's not just the weight loss effects that you see these blood pressure reductions.
Last time I spoke with you, we talked about AGs. We talked just briefly about anti-glycotic endpoints and how it hardens the skin and also, your vascular system. And you mentioned that the GLP-1s make your your blood vessels a little bit more malleable. Can you elaborate on how that works and how it makes things that stiffen up over time, the plaques in your arteries that build up, how it helps overall?
Yeah, so when you have cell death or apoptosis, what ends up happening is those cell fragments can, just like anything, when you get a cut on your body, that you form scar. These medicines help regulate cell death and apoptosis by helping either, there's a couple of reasons why we think it may be working this way, helping get rid of those fragments so you don't form scar. When you don't have scar, things are not as stiff. It helps improve relaxation. The other way is it helps essentially regulating oxygen in the cell itself. I'm going to take a quick side track and talk about the Tirzepatide and the glucagon. Glucagon also helps thermoregulation. So when we're cold, we shiver and our body temperature goes up. Glucagon helps with thermoregulation in a non-shivering way, which is fascinating. So these medicines are working on the oxidative phosphorylation system. So how electrons get transported on a cell level. And so when you are improving the cell overall machinery, you end up improving the overall cell structure and how nearly every cell in your body relaxes and functions. It's a pretty impressive system.
Mitochondria, the powerhouse.
Exactly, mitochondria and the electron transport chain.
You're repairing all of that. So do you see a day and time when GLP-1s may replace statins altogether?
I think they work differently enough that statins have their own benefit. You're talking about different cholesterol pathways and regulation of plaque forming. We don't see GLP, GIP working as about atherosclerosis. These medicines work in different ways, heart failure, kidney disease, diabetes space, but actual plaque forming is a little bit different process, macrophages and foamy cell accumulation. So there is still benefit in lipid-lowering therapies that are going to be additive to this class GLP medicine.
Your overall cholesterol and you're healthier overall, I could see, but so you don't see a time when GLPs would replace statins altogether?
I don't think if you have a need for a statin, I think that there's benefits of statins. I think where these medicines will help is help preventing you from needing a statin in the first place. So if you can help prevent yourself from getting to that ASCVD risk above 10%, then yeah, I don't need to prescribe you a statin. We've prevented that. We've saved you a medicine.
All right, just
Get that quite often. That's a lot. What are some of the unusual side effects of taking GLP-1s? There have been some reports of doctors prescribing them for addictions, such as for alcohol and smoking, shopping addiction. Can you touch on that?
Yes. So these are all off-label indications, but as you can see, that these medicines work in lots of different ways. In medicine, we call this pleiotropic, meaning it works all across the body. It's such an apt term for this medicine. Because this medicine works so well in the brain and helping with impulses and regulating essentially cravings, it was theorized or hypothesized that these medicines would work in other addiction disorders, alcohol addiction, tobacco use, drug use. And some physicians have been prescribing it for those reasons or for those indications and have seen good results and good success. There hasn't been any randomized trial against this, but I can't think of a reason why this wouldn't work in other mental health addictive disorders. I mean, it's worked in nearly everything else. There's no reason why it shouldn't, in my mind.
Do we know exactly why? Is it how it works on the dopamine pathways, how it works on the reward pathways? Can you elaborate a little bit more on that? Or is it just because your gut functionality improves and most of your neurotransmitters are made in the gut? I mean, like, what is it ultimately?
That's a great question. I'm not a neuroscientist. My understanding of it and what I explain to people is that there's two parts of the brain where, this works really well. The hippocampal pathway and then the hindbrain. So the front of the brain is more high level thinking. And then as we get more towards the back of the brain, cerebellum, it's more the stuff that we don't think about, the stuff that we just do naturally. So we don't have to think about eating. It's naturally what is expected of us as a human being. Because this medicine works in the hindbrain, in the reward center processing, the medicine has this additive effect of helping starve off or help prevent some of these abnormal cravings or accentuated cravings that we may be having. So when we think of overeating as a mental health disorder, because it's your brain needs food, it's just doing it in an additive, ramped up way. This medicine is help bringing it down to a more tame level, and that's all more hindbrain, back of the brain type thinking and processes.
Okay, so let's go back and talk to Dr. Sager, the cardiologist. Now you've improved the heart. What other things improve within the body once you improve the functionality of the heart?
Oh, there's so many things. So blood pressure is a very big one. I think what's very satisfying is when you have a patient that starts on this medicine, they start this journey, you are starting them on a very low dose of semaglutide, they start increasing, the weight starts coming down, and they're like, hey, doctor, my blood pressure is getting a little low. Can I come off this one? Yes, absolutely. Let's come off that medicine. Hey, my blood pressure is still a little low. So you end up decreasing the amount of medicines these people need. And that's very exciting. It's for lots of different reasons. Their heart functions better, their heart relaxation's better. They don't accumulate fluid on the body because your heart can pump more. Fluid doesn't build up as easily. So we're able to come off the water pill. We're able to come off the blood pressure pills. Hey, my diabetes is better controlled. We can come off insulin. So it's a really impressive medicine that touches on so many areas of the body that we were supplementing with lots of different medicines because that's all we had in our tool arsenal. But now we have this kind of Swiss Army knife medicines that allows us to tackle so many problems in one.
Which is great because all of these medications that we take come with so many other side effects, right?
Exactly. I don't like taking medicines. No one likes taking medicines. We do them because we think the benefits outweigh the risks. And when we can do it in a way that tackles so many different body problems, is really satisfying.
Yeah, benefits and the possible relief for those with autoimmune issues like lupus.
That's a great question. So we talked a little bit on the anti-inflammatory effects because this working in the cell membrane or cell transport system itself, you get improved cellular mechanics or functionality or machinery that decreases inflammation on a cell level. Where we still don't know is how this works on an immune level, how this works on B cells, T cells, et cetera. It's an incredibly interesting area. I'm really optimistic that it will help some arthritic and rheumatologic diseases, but we just don't know at this time. I mean, autoimmune diseases are so new in our understanding to begin with. And then when you add this medicine that we're still learning things about, I think only time will tell how it'll pan out. But I'm really optimistic.
And you touched on kidney disease, but can you elaborate a little bit more on how do GLP-1 medications help with kidney disease?
Yes. So since we've last talked, there was this big trial that came out, New England Journal, fantastic, called the FLOW study that looked at semaglutide in patients with diabetes and in patients with kidney disease. And what they saw was a massive 25% improvement in the time to dialysis, the time to kidney transplant, worsening of kidney disease. And it's for those reasons that we talked about because it does so much better at handling electrolytes in the kidney, lowering blood pressure in the kidney. Think of the kidney like a sieve. When you have a lot of pressure pushing in the kidney, lots of things are going to spill out. So when you can lower that pressure, you get time for the kidney to work, to reabsorb the things that it needs to get rid of the things that it doesn't need. And so you prevent progression of kidney disease. And this was proven and very well established now that these medicines help prevent kidney disease. The other thing is that it helped prevent cardiovascular death in patients that have diabetes and kidney disease as well, for a lot of those same reasons.
So obviously protein is recommended while you're taking these medications, but a lot of doctors also recommend hydrating and how important hydration is. Can you touch on why hydration is so important while you're taking GLP-1 medications?
Yes. So let's talk a little bit about when you come on these medicines, what's your journey? How are you going to feel? What are the things that you need to do? When you are on this medicine, you're going to feel full. The worst thing you can do is stop eating altogether. What ends up happening is you're going to start losing muscle mass, not in a good way. You're not going to lose just fat. You're going to start losing muscle mass. We call that sarcopenia. We want to prevent that. We want your body to retain muscle while lowering fat. So having healthy exercise, doing strength-based training, and everything else that a doctor tells you in terms of exercise is still important. Because your body is getting used to this new level of hormones, your kidney is starting to process things differently. Sure, you're hydrated is very important. You're giving your body time and chance to regulate itself in an appropriate way. The benefits that you see with these medicines also extend beyond just the kidney, heart, body system. One thing we've not talked about in this entire 45 minutes, which is still impressive, is bone health. So the way GLPs work on bone is also impressive. So on your bone, you have osteoblasts. Blasts build bone is how I remembered it in medical school. So GLPs act to improve osteoblast function. So you improve bone formation while decreasing osteoclasts. Osteoclasts resorb bone. They get rid of bone. So bone health is also improved with these medicines. So you need to still have strength training. We know strength training helps preserve bone function. We know GLPs help build bone. If you don't work out, if you aren't still doing your normal healthy exercise, you're not giving the medicine its maximum efficacy, maximum effect of helping preserve bone function. It's like for the same reasons why for osteoporosis, we recommend strength training, not just walking and cardio, but putting a stress on the bone helps improve the bone formation. Think of it the same way. Once you start GLP medicines, we want you to still do strength-based training exercises to help preserve the bone formation.
Well, thank you for touching on that. Thank you. I want to take some of the questions that came in the chat. So someone said, you touched on these medicines helping with infertility. What has been studied about pregnancy in these medications?
Oh, that's a great question. So it's very, very hard to do a full study on medicines in pregnancy. I mean, it's very hard to have people enroll in a study. So the default answer for a lot of these is if you're on GLP medicine and become pregnant, a lot of times we tell you to come off. And that's only because we don't know. It's hard to prove that these medicines are safe when you don't do a study. So the default answer is to come off and do things that we know are safe, like insulin or other medicines. I'm very hopeful that we will be able to show that these medicines are safe, because dosing insulin when you're pregnant is very cumbersome. Gestational diabetes is a real problem that people in my family members have suffered from, and I don't like seeing people go through it. But at the same time, we don't know if these medicines cross the placenta. We don't want the baby to have hypoglycemia or changes in their glucose regulation. So the safe answer, until we know more, is to come off and do what has been proven to be safe and effective.
And do you know how long, a question just came in on this topic, how long you should be off the medicine before you get pregnant? Is there a recommendation in the medical field?
These medicines don't stick around too long. So even a week and the medicine's mostly out of the body.
Okay, so for all those Ozempic babies, you're safe, you're good.
Mm-hmm.
Have you seen a switch in the medical field as a whole to prescribing this more than the past for reasons other than diabetes and weight loss?
100%.
Mhm.
Even in the decade that have been around medicine, is a lot of times cardiologists would never prescribe a diabetes medicine. And because we now know that these medicines are labeled for cardioprotective benefits, for sleep apnea benefits, for kidney disease benefits, they are much more commonly prescribed for those reasons. So you have patients with diabetes that we can give these medicines, but you also have patients that we want to lower their cardiovascular risk. We can give them these medicines. It just adds a really nice tool in our arsenal that is kind of a Swiss Army knife, like we've been talking about, that we want to help come off diuretics and blood pressure medicines and a whole swath of other things. It's been pretty impressive and helpful. The challenge is getting these medicines. So their insurance makes it very hard to obtain. So having other avenues where you can get them is really, really beneficial. And frankly, what I've recommended to a lot of my patients as well.
Let's talk a little about hormones and GLP-1s. Do you see that hormones balance out, or what happens to our hormones once we, one, lose the weight or while we are on these medications? What are you seeing in the medical field?
That's a great question. So you do see, so let's say, for example, in diabetes, when you have diabetes, you have problems with insulin regulation. You get on one of these medicines that helps improve insulin regulation. You lose weight, you help rebuild some of the body's natural processes. Then, hey, all of a sudden, yeah, my body is processing things more normally. Maybe I can come off them for diabetes. Maybe my pancreas is now ramped up. I'm secreting GIP and GLP more naturally from the pancreas, that I don't need to supplement it with semaglutide, for example. That's entirely possible. And frankly, we see it. And if you stick to it and are very regimented and take these medicines as appropriate, yeah, I absolutely can see that hormone regulation improves with the use of these medicines.
Information on when someone has total loss on one side.
So these medicines have been shown to prevent stroke. So when we talk about cardiovascular death, the vascular and cardiovascular includes stroke. A lot of times it's from atherosclerotic stroke. So when you have plaques in the brain, that was an outcome in a lot of these trials. Where stroke has already formed is, first off, very challenging, and repairing the damage that's been done to the brain is not something that's typically seen with these medicines. It's something that I wish these medicines could help do, but repairing the damage of the brain structure is after scar is formed.
Sorry about that.
To bring back cells that have already gone.
Now, as far as your body adapting to these medications, are you seeing any reports of that where patients have to keep titrating up and then there's a point where this medication just doesn't work for them anymore? Or no, there's just no possible way to reach that?
If you asked me this a year ago, I would have said that no, there's no possible way that people can reach that. I think now we are learning more that, people do get more adapted to these medicines. And so, for example, if you're on semaglutide and you go up to 2.4 milligrams of semaglutide, which is a big dose, and you're still not achieving the results that you want, that's where having another tool like Tirzepatide really comes beneficial. So you can go from semaglutide to Tirzepatide and then dose up with Tirzepatide to the max doses that you can tolerate. I haven't seen people max out Tirzepatide yet personally. But theoretically, if that does happen, I'm sure and I'm confident down the pipeline, we're going to have another tool in our arsenal, whether it's a completely other medicine that's like more neuroprotein YY or one of the triple agonists that we talked about. So there's lots of ways that we can combat that even if you are on the maximum dose.
Or maybe there's an underlying issue, right? There's another metabolic disorder, there's an underlying issue, and you should get checked out.
Yeah, and making sure you're taking the medicine the right way. Sometimes alternating sites. So if you're always somebody that injects it in the stomach time after time after time, maybe going to the other side or trying your thigh. There's lots of other things we can try. Agreed.
This is a good question because I'm getting seeing some very similar ones come in about the difference between semaglutide and tirzepatide. Is one, are you seeing one's more effective than the other? I mean, I can speak from personal experience. I lost some weight on semaglutide. I went on tirzepatide and fast tracked it, and then I started getting some, a little bit of like heart palpitations and anxiety. And so I came off of it. I went back on semaglutide. It worked perfectly. So are you seeing that switching effect helps, or are you seeing more benefits on one versus the other? Is it just dependent on your body? What are you seeing?
Well, I think it's very interesting because we talked on the tachycardia, ramping up the heart with the more that you add some of these hormones. It's very possible that's what you experienced, and not surprising me. I'm sorry that happened, but I'm glad you're better. I think we know from studies, there was actually a trial that compared semaglutide to Tirzepatide on weight loss, and Tirzepatide markedly had higher weight loss than semaglutide. And that's because, as we expect, the additional hormone that's in the medicine, just like retatrutide, outperformed Tirzepatide. When you talk about cardiovascular risk, we don't know for sure if one is better than the other yet. We know that they work. We just don't know. We don't have any head-to-head comparisons on cardiovascular risk. The other thing we know is that with more hormones comes more side effects. You do have more delayed gastric emptying. You feel more nauseated. You do have some more GI upset with Tirzepatide compared to semaglutide. This is another reason why we start slow and ramp up. It's another reason why a lot of times people start with semaglutide first. And then once you've reached semaglutide, switching over to Tirzepatide is another strategy. So a lot of, like we said, it's very well understood that these medicines are same but different. And with more hormones comes more weight loss, but also at the expense of possibly more side effects.
So we know these medications have been a game changer. They are going to be the medicine of the century, I would even say, right? After insulin, this one's like the next big one that has come out. So let's think about the future. Okay, we have different classes coming. They're going to be more and more effective, right? That's what we can anticipate in the next couple of years. But so we have a population that has lowered their weight. Where do you see medicine heading? What is next? What is the future of medicine?
Yes, I think this was laid out very nicely in so many cool papers where they talked about the future of GLP medicines. And there's lots of other medicines that are in the pipeline. So for example, amylin analog, amylin's another hormone that's produced by the pancreas. This has been around for over a decade. Weight loss, much better safety or side effect profile, except it's a 3-time-a-day injection. That's why no one uses it right now. So changing the formulation of these medicines to being longer acting so that you only have to do injections once a week, once a month, once a year, ideally, is where a lot of the future drug development is going. The second is in understanding where these medicines work and why these medicines don't work in certain people. I just submitted a grant last week, I kid you not, on trying to identify who benefits most from GLP medicines. Hope it gets funded, but it's a really exciting area of research. And it's exactly like we're talking about, trying to find the right medicine for the right patient at the right time. So some patients may still benefit from GLP while some may be neuropeptide YY, for example. And it's really exciting in that for the first time in the last century, we now have a plateau and a little drop on the US obesity demographic. For the first time, the rates of obesity in the US are coming down, which is so exciting. Cardiovascular disease is going down. It's not just body weight, it's the whole body effect of metabolic syndrome that's improving the landscape with these medicines.
Well, I don't know about you, but that was a great interview, and the information is so important. So if you've been fearing these GLPs, I hope this kind of puts some of those fears at rest, and know that doing the right dosing, having a quality compounded version of this, because if you're not meeting the requirements, your insurance is not going to pay for it, and it is very expensive. So when you look at the compounded versions, they're very safe in most cases if you're working with a qualified health professional or a great telehealth platform. But if you have any questions, please reach out to us. In the description, I will have an email where you can send any kind of inquiries. And if you'd like to know where you could get your GLPs and some other peptides, we do have a concierge wellness telehealth platform that we can help people all across the country. So if that's something you're interested in, or if you're local, you can come on in. We're a little bit cheaper than most of the telehealth platform companies and even local places. And we'd love to have a conversation with you if you're local here in Wisconsin. All right. Have a great rest of your day or night, depending when you catch this. And if we can help you, we'd be happy to.